We'll get started in just one moment. All right, so hi everyone. Welcome to the virtual webinar on adult hepatitis B vaccination. My name is Michaela Jackson, and I am the Prevention Policy Manager for the Hepatitis B Foundation. And I'm also going to be moderating today's session.
Okay.
So first off, I would like to thank all of our wonderful co-hosts for partnering with us for this briefing. We are very excited to be here with you guys and discussing vaccine and health equity today in the context of hepatitis B. And they're all wonderful organizations. And if you're not familiar with them, I encourage you to go and familiarize yourself and check them out. And so the reason that we're holding this briefing today is because tomorrow, April 30th, is National Adult Hepatitis B Vaccination Awareness Day. And that is something that's really exciting for the hepatitis B community because across the United States, only about 25% of adults are fully vaccinated for hepatitis B. And this is despite having highly effective vaccines for nearly 40 years now. And so you can see on the screen, we have 3 goals that the Vaccination Awareness Day is really out to achieve. And the end goal was really health equity. We know that hepatitis B can be eliminated in the United States. And the one way through that is through increasing hepatitis B vaccination amongst adults. And so we have a great list of panelists that are coming up for you today that will be discussing hepatitis B in the context of health equity, and we're really, really excited about that. And one other thing we're really excited about is that Senator Hirono and Representative Johnson have agreed to introduce, or reintroduce, I should say, the resolution declaring National Adult Hepatitis B Vaccination Awareness Day as April 30th. And we're very excited to see where that goes and how that can help increase awareness. So thank you to them. And next up, I am just going to go through, we have a list of wonderful panelists that are here. Oh, sorry, 1 second, can you guys see the slides moving? No. Okay. Can you see that now?
No.
No?
No.
Okay. Apologies for technical difficulties. There's always something. All right. Let's try that again. Can you see the panelist slide? Okay, perfect. So there we go. So we have a list of 7 great panelists that will be discussing hepatitis B in various contexts in terms of challenges accessing the vaccine, health disparities with hepatitis B and vaccination, and also the universal recommendation for adult hepatitis B vaccination that may be happening right now. The ACIP, so the CDC's Advisory Committee on Immunization Practices, is undergoing an analysis to see whether or not it would be feasible to recommend universal adult hepatitis B vaccination. And that would be extremely helpful in increasing awareness around hepatitis B vaccination, the fact that adults even need it, and also for individuals and groups who are implementing it on the grounds, because perhaps we can update guidelines and really help the organizations who are working so hard already to now increase their vaccination rates. And so we're very looking forward to the end of the year in October when that discussion is happening, and we're excited to see where that goes. And next, I am going to introduce a woman who really needs no introduction. Representative Grace Meng is a fantastic champion for hepatitis B and the viral hepatitis space, and we're very happy to have her on this call today. And we thank her for all of the work that she's done in the policy community for hepatitis B and viral hepatitis, and I can turn it over to her now.
Thank you so much. Thank you for having me today, and thank you for including me in today's event. I'm Congresswoman Grace Meng from Queens, New York. I want to thank the Hepatitis B Foundation for hosting today's briefing in advance of National Adult Hepatitis B Vaccination Awareness Day, which is tomorrow. Thank you to all the advocates and leaders here for your tireless commitment to ensure everyone who needs a vaccine receives one. And finally, as co-chair of the Congressional Hepatitis Caucus, I want to recognize my friend, my fellow co-chair, Congressman Hank Johnson, who is a tremendous ally and partner on many issues, but especially in this space. Together, we are committed and laser focused on securing increased resources to combat hepatitis B, ensure that everyone is tested, and broaden access to care. According to the CDC, there are nearly 6 million people in the US who are living with the hepatitis B virus or hepatitis C virus. Despite its prevalence, awareness is low. Close to 3/4 of the population infected with either virus are unaware of their condition and therefore go without the necessary life-saving treatment they require. Furthermore, HBV disproportionately affects Asian Americans and Pacific Islanders, who account for over half of HBV cases, but make up only 7% of the population in the US. Over the last year, COVID-19 has negatively impacted prevention efforts as people stay home. Many health departments' viral hepatitis services foresee a reduction in outreach, education, and testing. This has been deeply troubling, but it must be a rallying cry to redouble our efforts to combat the hepatitis B virus. Today's event to highlight National Adult Hepatitis B Vaccination Awareness Day is critical to this effort. We have a moral duty to spread the word on how to get tested and treated. As we work to rebuild our country, I'm confident we will continue to partner together and work toward fighting the virus. Thank you again for all that you do, and I wish you all a very productive briefing. Thanks so much.
Thank you so much, Representative Meng, for your remarks. And now I will pass it over to Dr. Weng to get us started on the panelist section of it. And so just as a note for you all, we have 7 great panelists who'll be providing brief presentations for you all. And then we're going to turn it over to a discussion portion that will take up most of the briefing. So please feel free to drop your questions into the chat box. Thanks.
Hey, thanks very much. Good afternoon. This is Mark Weng with the CDC. Thank you very much for having me here today. Next slide. I want to first tell you about my uncle, who was an immigrant to the US, arriving in the 1970s. He and his wife took care of me soon after I was born, as my own mother had to go back to work quickly after delivering me. Sadly, just a few years ago, my uncle passed away because of complications from hepatitis B. The US over the decades has since made advances with this now preventable disease, but there's still a ways to go. So I'd like to spend a few minutes to quickly give you the story and context and numbers, and it should then become clear as to why the organizations represented by this panel today and many others are investing the time and resources right now in addressing one of our solvable national public health problems, hepatitis B. The annual reported number of hepatitis B cases persisted in the US over the past 10 years, despite the availability of a safe, effective vaccine. Next. CDC has estimated that about 862,000 people are living with chronic hepatitis B in the US. But more recent studies have indicated that this number could be closer to an estimated 2.4 million people. This is something CDC is in the process of verifying. Next. This is made worse by the fact that almost 3/4 of those infected, as Representative Meng just said, are not aware that they're infected. Next. Consequently, about 40% of people with hepatitis B develop serious medical conditions like liver cancer or cirrhosis. These long-term diseases cost lives and become very expensive to treat. Next. For a chronically infected patient with private or employer-based health insurance, healthcare costs to treat one of these serious conditions can average between $124,000 to $172,000 each year. Next. But it's not all bad news. There is a way forward. As you can see in this graph with years going horizontally and cases on the vertical, there's been phenomenal progress in decreasing new hepatitis B cases in the US over the past 4 decades. It's primarily driven by expanding vaccine recommendations to more population groups. First, in 1982, hepatitis B vaccine was recommended for people at increased risk. There's a long list of risk factors for getting hepatitis B vaccination. Some are as simple as being healthcare personnel or being a household contact of people with hepatitis B infection, while others could be considered more stigmatizing in some settings, like drug use, sexual contact, or HIV infection. It's stigma that can be a barrier to preventing these preventable deaths, even while our country has some great tools like hepatitis B vaccine. Then after 1991, when all US infants were recommended to be vaccinated against hepatitis B, and after 1999, when all children were recommended to be vaccinated, rates of acute hepatitis B dropped and remained low in children and adolescents. But the last mile to achieve further decreases in adult infections has proven challenging. Over half of acute hepatitis B cases reported to CDC in 2018 were among people aged 30 to 49 years. These are folks who potentially have a lot of working years left in them. And the actual estimated hepatitis B infections are most likely much higher than those reported to us. So among CDC's response to help make further achievements in hepatitis B prevention possible include CDC's new funding opportunity for integrated viral hepatitis surveillance and prevention, which includes helping health departments increase hepatitis B vaccination among adults at increased risk. That's $341 million over 5 years awarded to 59 jurisdictions. This is important to us. We're also reviewing evidence for consideration of new recommendations for universal hepatitis B screening and vaccination of adults. My co-panelists will next delve into some of the complex reasons for why and how these hepatitis B cases currently persist, from patient, health provider, to systemic factors, and how by addressing these factors, it is possible to end hepatitis B. Thank you.
Wonderful. Thank you so much, Dr. Weng. That was wonderful and so informative. My name is Abby Bownas, and I'm grateful to be here with you all today. I manage the Adult Vaccine Access Coalition. We are a DC-based organization that works to increase access and utilization in the adult vaccine space. Many of our partners are here at the table today, so thrilled to be here with you all, and just wanted to offer a big thank you to Hepatitis B United, Hep B Foundation, AIDS Institute, Asian Pacific Community Health Organizations, the National Viral Hepatitis Roundtable, and the National Consumers League, all for joining in co-sponsoring this wonderful event. You know, I think the COVID-19 pandemic has just shown us once again what I think we've all known to be long true, which is the value of vaccines, which help us mitigate disease, they prevent severe illness, reduce rates of hospitalization, morbidity, mortality. And so while here we're talking about hepatitis B today, AVAC works to promote all of the recommended vaccine set. There's actually over a dozen vaccines that are recommended in the adult space. And I think the unfortunate reality is that even before the COVID-19 pandemic, adult vaccine rates were very low and far lower than where they could and should be. I think the COVID pandemic has just heightened that need in terms of even further drop in recommended vaccines. So we will have some work to do moving forward in terms of getting those rates back up to where, hopefully beyond where they even are at the moment. Adult vaccine uptake varies greatly by vaccine, and then there's a whole host of other factors that, you know, if you start to break it down, you see difference by ethnicity and gender, geographic location, socioeconomic status. And so as you heard, I mean, when we're talking about hepatitis rates for the adult population, right now it's at 25% of the population. So I think it's really important that we think about how we can increase that, especially with the aging of the US population. What we have to do is really think about how we can be improving access to vaccines, because as we age, our immunity lessens, and it's all the more important that we make sure that everybody receives their routine immunizations. I'm just going to talk a little bit about some of the barriers, because I think the adult vaccine space is just a little bit more complicated than our childhood vaccination process, which happens in one provider community at the moment. There's so many reasons why our vaccination rates are below where they could be. And barriers really range everywhere from just people not knowing what vaccines are needed for them or when, people being hesitant to receive because they don't have the information. But there's also barriers like financial barriers. And that's one of the ones you can see in this infographic really can make a difference in the population in terms of whether somebody decides to get vaccinated or not. There's also provider barriers and how we pay the providers that are offering vaccines. Those differ depending on the space, private insurance, and through the federal healthcare system. So we could talk a little bit about what some of those challenges look like as well. There's also a whole host of logistical and behind the scenes things that make adult vaccination complicated. Including the lack of use of some of the technology that is available now, like the immunization information systems, which can help us figure out where the gaps are and how to get into those gaps. And then also the fact that we have a broad stakeholder community. I think we've seen them come really together over the last few months around the COVID vaccination campaign. We want to harness those efforts and have them move forward. Next slide, please. Our coalition is working to think about those barriers, but also think of solutions for them. I think sometimes knowing the challenges also helps us make the recommendations on how to improve the landscape, and that's what we're hoping to do to achieve more equitable vaccine access. So we're seeing some of this come to fruition today. I think, again, with the COVID vaccination campaign, which is the biggest we've seen. My sincere hope is that these efforts can continue as it relates to hepatitis B and all routine recommended vaccines. And so there's a number of things that I think we can be doing, and some of those topics are highlighted here. I'm sure we'll get into some more of those as the conversation continues. But just to note a couple, I think infrastructure is so important in terms of making sure that we have a strong immunization infrastructure to be able to get vaccines out to the needed populations. I think there's been some recent investments in terms of infrastructure, but I think we've also seen where some of the gaps are and where the opportunities are to continue to fund. I think in terms of the immunization information systems is a great example because we can be funding the technology. Equity is something, again, that I think has been around as a challenge for a long time in terms of vaccination. And I think it's an opportunity for us to be thinking about how to better reach our older adults, communities of color, those with limited English proficiency, and then at-risk populations, pregnant women, as well as those with chronic illness. There's the cost. I think we touched a little bit on this, but cost really does impact people's decisions in terms of whether or not to receive a vaccine. And so we want to be taking that off the table as much as we can in both the Medicare and the Medicaid setting. We also want to just think of what education efforts are needed and who are the messengers to get those messages out to the right populations. And so I really look forward to a continued dialogue and conversation as this panel moves forward. And thank you again for having me here.
Hi, my name is Rita Kuwahara. Thank you for the opportunity to speak with you today on the opportunities that exist to increase adult hepatitis B vaccination in primary care. Next slide, please. As a primary care internal medicine physician caring for patients at a federally qualified health center, I have seen firsthand the devastating effects that chronic hepatitis B has had on my patients. Hepatitis B is a leading cause of liver cancer, and 1 in 4 individuals with untreated chronic hepatitis B will develop liver cancer, liver failure, and or cirrhosis. Liver cancer represents a particularly difficult diagnosis as the 5-year survival rate is less than 20%. FDA approval of the first hepatitis B vaccine in the early 1980s was a landmark event in medicine, as it represented the first anti-cancer vaccine to be developed. And since then, several additional highly effective vaccines that protect against hepatitis B have been approved. Most recently, the 2-dose Hepatitis B vaccine that provides full immunity against hepatitis B with 2 vaccine doses over a 1-month period, rather than the traditional 3 doses over a 6-month period. When universal infant hepatitis B vaccination in the US was recommended in the early 1990s, this represented a defining moment in our nation's ability to potentially eliminate hepatitis B. Implementation of universal infant vaccination varied from state to state, so only fully vaccinated children born in the US starting in the mid to late 1990s were reliably vaccinated against hepatitis B as infants and children. While it is wonderful that children and young adults up to the age of around 20 to 25 years old who are born in the US are now vaccinated against hepatitis B, the majority of adults over 25 have not, or over 19 have not been vaccinated, as adult hepatitis B vaccination is not currently universal and requires a risk-based strategy to determine which adults to vaccinate. As a result, only 25% of adults over the age of 19 are vaccinated against hepatitis B in the United States, with lower vaccination rates among certain subgroups. For example, only 12% of adults with diabetes over the age of 60 are vaccinated, representing significant opportunities to increase adult hepatitis B vaccination. The importance of increasing adult hepatitis B vaccination has become even more important in the setting of the opioid epidemic. In fact, Maine experienced a 729% increase in acute hepatitis B from 2015 to 2017. The Appalachian states of Kentucky, Tennessee, and West Virginia saw a 114% increase from 2009 to 2013. Southeastern Massachusetts had a 78% increase in 2017, and North Carolina had a 62% increase from 2012 to 2016. These sharp rises in acute hepatitis B were driven by the opioid epidemic and fueled by a very low adult hepatitis B vaccination rate. Now, with the COVID-19 pandemic and surge in opioid-related overdoses and deaths, we are very concerned that many more individuals across the country are at risk of acquiring new hepatitis B infection, and it is important to act now to prevent acute cases of hepatitis B through expanded adult hepatitis B vaccination. Next slide, please. Primary care physicians play a key role in increasing vaccination rates for their patients, and it is vital that they help to lead the role in increasing adult hepatitis B vaccination. However, many primary care physicians are not aware of the low hepatitis B vaccination rates among their adult patients. In a survey of primary care physicians caring for adults that we conducted, we found that 0% of surveyed physicians realized the adult hepatitis B vaccination rate was only 25%. Instead, 86% of surveyed physicians incorrectly assumed that the adult hepatitis B vaccination rate was 75%, and as a result, few routinely thought about testing and vaccinating their patients against hepatitis B, even though they reported routinely caring for patients with underlying conditions and risk factors that would make them at risk for acquiring hepatitis B infection. The main reason cited by surveyed physicians for not routinely vaccinating their adult patients against hepatitis B is because they incorrectly assumed their patients had been fully vaccinated as children by their pediatricians and were therefore already protected. They did not realize that universal childhood hepatitis B vaccination was only reliably implemented in the mid to late 1990s across all states, placing many of their current adult patients in the age range most affected by the opioid epidemic at risk of becoming infected with hepatitis B, since they were never vaccinated. Our findings highlight the importance of increasing awareness of the low adult hepatitis B vaccination rates among primary care physicians caring for adult patients in order to increase vaccination rates. We must simultaneously raise awareness of this issue in the larger community so that patients are more likely to ask their physicians about hepatitis B testing and vaccination. While there is no cure for chronic hepatitis B, we have the tools to prevent acute rises in hepatitis B infection and the subsequent consequences of hepatitis B infection, such as liver cancer. But in order to do so, we must act now to prevent additional outbreaks of acute hepatitis B within the opioid epidemic and COVID-19 pandemic. I've always said and will continue to say that vaccination is always the answer in public health, a strategy that has been further highlighted during the current COVID-19 pandemic. When highly effective vaccines exist to prevent diseases such as hepatitis B, we should not have a single new infection of hepatitis B if we are able to provide the hepatitis B vaccine to every infant, child, and adult in our nation. And we must work together in a bipartisan fashion and in coordination and collaboration with our public health, clinical, and community partners so that we may finally eliminate hepatitis B in the United States. Thank you.
Oh, Dr. Feinberg, I don't believe we can hear you.
Thank you. You'd think after a year of Zooming, you'd do that. Okay, well, thank you very much. I'm delighted to join you this afternoon and talk to you about the impact of the opioid epidemic on hepatitis C in West Virginia. Next slide. So as you can see on the right-hand side of this slide, the rate of acute hepatitis B in West Virginia has been climbing since the early, the start of this century, and the rise completely coincides with everything else that's involved with the opioid epidemic, like overdose deaths and hepatitis C. And in fact, West Virginia has had the highest rate of acute hepatitis B for the past decade. And we are head and shoulders ahead of all the other states, which is interesting and especially problematic because we have a very strict childhood vaccination regulations in order to go to school. And so, as previous speakers have noted, when the birth dose vaccination for hepatitis B started in the early 1990s, we don't see hepatitis B in children born after that period. But this rising incidence of hepatitis B is all in people who were born before 1991. And on the left-hand side of the slide, you can see that the chronic Hep B rates track very closely with the acute Hep B rates. In fact, they really overlap. Next slide, please. So on the left-hand side here, you can see the acute hepatitis B and acute hepatitis C rates. And this looks like the acute hepatitis B rates have gone down a bit, or we are still have the highest rate in the nation. And you can see that the acute hepatitis C rates are increasing dramatically. And again, the time period totally coincides with the injection drug epidemic. On the right-hand side, you can see the proportion of cases of hepatitis B and hepatitis C that are related to specific risk behaviors. And so you can see that injection drug use and the use of street drugs are by far and away the most common causes of both acute viral hepatitis, but also incarceration and contact with the case, and non-professional tattoos follow. Next slide. So of course, if you have a lot of women of childbearing age, which if you were born before 1991 would make you in your late 20s now, and we typically think of childbearing age as being 15 to 44, then it makes sense that these blue bars have been increasing over time, which is women who are pregnant, who have chronic hepatitis B, and therefore are at risk of transmitting it to their newborn. And actually, hepatitis B is serious as it is in adults. It is really a tragic disease in children. And you can see that, in fact, of course, that the inevitable has happened, right? That women have given birth to infected infants. A study that we published about a year ago where we looked at hepatitis B blood tests nationwide using the Quest Lab database in women of childbearing age, so 15 to 44, we saw a dramatic increase in acute and chronic hepatitis B in women who were older, too old to have received the birth dose vaccination, which started in the early 90s. So the people at risk now that we are really concerned about are the people who were born before these new vaccination procedures were put in place, and they remain at high risk because of the ongoing injection drug epidemic, which sadly now is not just opioids, but now opioids and stimulants like cocaine and methamphetamine. So rather than the injection drug epidemic calming down, if anything, it is actually ramping up as other drugs become more prevalent in the community. So that, I believe, is my last slide, and I just want to impress upon you once again that hepatitis B and hepatitis C are absolutely the consequences of the drug epidemic. And as long as we have the drug epidemic ongoing. We will see this, and although we do not have a vaccine for hepatitis C, we certainly do have a protective vaccine for hepatitis B, and it is an absolutely urgent issue to vaccinate those adults who are at risk. Thank you.
Hello, everyone. Thank you for having me here today. I will be focusing on the Asian American and Pacific Islander populations. Next slide, please. So just to give you a basic idea about our community health center, we are a federally health qualified health center based in New York City. And we primarily serve the low-income Asian immigrant community. 80% of our patients speak other languages other than English, and about 63% of our patients are either uninsured or on Medicaid. So as you can see, there's already a barrier there for medical care. Next slide, please. In the Asian American population, to reiterate the point made by Representative Grace Meng, there's more than 50% of cases of chronic Hep B in the US made up by the Asian American adults. Within the Asian American population, there's about 10% are infected with hepatitis B and have chronic Hep B. And if they are unmonitored or untreated, 1 in 4 of them will die prematurely from a liver condition related to Hep B, either from liver cancer or liver failure. So it's very important to monitor and treat these patients. And we actually did a study of our own patient populations spanning from 1997 to 2017. And we saw that about 52% were ever infected by hepatitis B, and only 33% immune from vaccination, and still 14% are susceptible to infections. Next slide, please. So, next slide, please. So to address all these issues and problem in the Asian American community, at Charles B. Weng, we do universal Hep B screening for all adult patients. And we do this to try to get as many people to be aware of their status as possible, whether or not they have the hepatitis B or they need to be vaccinated. So I think universal screening is very important to catch all those people who don't know the diagnosis. And we also try to provide free screening for community members, for anyone who walk in and want to be screened. And along with that, to provide free or affordable Hep B vaccinations for uninsured patients with the help of a local health department. And those are important addressing the cost issue for patients, especially with our patient population with 63% are either underinsured or uninsured. And to address the issue of the language barrier, we do provide educational material in Cantonese, Mandarin, and Vietnamese, and of course also in English for patients who can read it. And we do provide Hep B care for patients who are diagnosed with Hep B. For the adult with high-risk chronic Hep B, we monitor their condition. We educate them about their condition, and also very importantly is for them to screen their household contacts and any other contacts and their family members. We coordinate care for them and try to help them with antiviral treatments, free or low-cost treatments. And the important program we have is also for the pregnant women, the Hep B Mom program. This is very important in prevention of further Hep B infections. It would work toward the goal of hepatitis eliminations. So we educate pregnant women and monitor them during the pregnancy, educate them about giving their infants vaccination at birth and also immunoglobulin to prevent the transmissions, and to screen their family members and other contacts. We try to track the vaccine record of their infant to make sure that they get fully vaccinated and follow up properly. So these are the few steps that we try to take to address the disparity in the Asian community, Asian American community, to improve the care for them. Thank you.
Thank you. So I'll be discussing some barriers to care in South Florida. Next slide. So as noted by Dr. Weng, recent estimates suggest that the prevalence of chronic hepatitis B in the US approaches 2.5 million. And we know, as previously discussed, that certain communities are disproportionately affected by hepatitis B, and this has contributed to racial disparities in liver cancer. So we did an evaluation of 1,000 patients who had liver cancer in our center, and we found that there were significant differences in terms of the rates of hepatitis B infection. We found interesting, like 35% of Black patients had hepatitis B compared to only 6% of white patients and 60% of Asian patients. But what was more impressive were the disparities in treatment. So while 75% of our Asian patients and 68% of our white patients with hepatitis B related liver cancer had been previously treated, this number was only 39% in our Black patients, which suggested that they had not been screened and were unaware of hepatitis B as a risk factor. And as mentioned previously, undiagnosed and untreated hepatitis B contributes to late diagnosis of liver cancer, which decreases survival. So hepatitis B vaccination is critically important to prevent transmission in those communities that are disproportionately affected by hepatitis B and liver cancer. And it was really clear in our catchment area that Blacks were disproportionately affected. So we decided to focus our efforts on better understanding the community needs. And I'll talk about that in the next slide. So vulnerable communities in our catchment areas are not informed, they're not aware of Hep B risk, and that's been stated at least twice already. So we were interested in understanding the perspective of the Black community members because they're disproportionately affected by hepatitis B in our catchment area, which is in green. It's 4 counties. South Florida is incredibly diverse. There are large communities of immigrants from South America as well as the Caribbean who have increased risk for hepatitis B, which is shown by the colors in the map in the middle. So what we decided to do is conduct focus groups in persons that were born either in the United States or in Haitian Americans. And we grouped our groups according to where people were born, their gender, and whether or not they had been diagnosed with hepatitis B. And we had 55 who participated, 27 from the United States, and 28 who were born in Haiti. And we found that fewer members of the Haitian community were aware of hepatitis B as a risk factor prior to the focus groups. And this was particularly concerning because based on our map, you can see that certain countries are at higher risk, and Haiti is one of those countries that's thought to be at risk with either intermediate or high risk of hepatitis B infection. So in addition to the low awareness, they had a lot of misconceptions about hepatitis B could be spread. And what we did is ask those participants what we could do to increase awareness and improve screening for hepatitis B. And what they recommended was using public service announcements, social media, utilizing schools and universities to educate the community, as well as enlisting some community leaders to promote awareness, as community members would be more inclined to listen. Some recommended that we do some town hall sessions with people who were able to explain the disease. And the major issue that our participants mentioned was that there's an issue with access to care. And this is a direct quote from one of them. If we could get tested in our community or at a center in our community, that would be great, because a lot of people can't afford to go to the doctors. What many participants suggested was a confidential mobile testing unit. And next slide, please. So on the basis of the advice of our focus group participants, what we decided to do was to do a pilot study where we looked at acceptability and feasibility of doing screening either at home or in the community among Haitian immigrants. And this work has been done in other communities, but no two communities are the same. And it had not been done in our area in this community. And we focused on this group given the increased disease burden that I already mentioned. So we used community health workers, and the participants did a questionnaire to say whether or not this was acceptable, and we had 60 and 59 found it to be acceptable. Only 1 had a fear of needles. And so of the 53 who had the blood drawn, we found some things that were really concerning. 45% had been previously infected with hepatitis B, and nearly half were vulnerable to infection. Less than 6% had been vaccinated. So respondents did give us a lot of information on why community members might find screening unacceptable. But clearly, this high rate of prior hepatitis B infection highlights the need for effective outreach programs. Since home-based screening is acceptable, home-based or community-based vaccination might also be acceptable. And we're exploring that currently.
Good afternoon, everybody. My name is Monde Nyambe, and I'm a hepatitis B coordinator at the Illinois Public Health Association. Next slide, please. So we all know that there is a lot of health disparities when it comes to African immigrant populations. And with COVID, we've kind of noticed that these health disparities are occurring across the board. And so some of the things that we can do to address those health disparities is to be inclusive. What do I mean by being inclusive is we should have a representative of people that are of African origin in the healthcare work settings. And when I say that, I mean like community health workers. So if we train community health workers and they become part of our clinical staff, then we are being inclusive and more inviting to the people that we are supposed to be helping. And the other problem is cultural and linguistic barriers. Most of the African immigrants are very limited English proficiency. And so if they go to a place where they feel like their language needs are not met, it becomes very difficult to open up with what is really going on in their life. So having interpretation services, as well as having like community healthcare workers again, could help at least to reduce some of these disparities that this community is facing. Next slide, please. So how can we improve vaccination rates in the African immigrant communities? By developing trust with the community members. How do we do this? We can have like gatekeepers in the communities that we can use to deliver the message to the people that live in the African community. And we can also improve on the linkage to care process, because this is not something that's easy if somebody doesn't really speak English. So for example, somebody might go a healthcare center, and that healthcare center might not have the interpretation services right there when the person is making that phone call. So if we have like direct lines for people that have limited English proficiency, this might help to reduce the problems that we are facing in linkage to care situations. We can also implement point of care in terms of outreach settings, just like what Dr. Patricia Jones said. In outreach centers, we can have sorry. In outreach centers, we can have testing done there, and we can also have all the vaccines done when a person comes for that particular visit. The other thing, we can develop rapid home and testing kits, just like what they've done with HIV. That's something that we've seen that it's working. So maybe in the near future, we can have these home-based testing kits available as well for hepatitis B. Next slide, please. So these are some of the challenges: availability. How available is the hepatitis B vaccine? It's not very easy to come across these vaccines because of cost. So if somebody is underinsured, uninsured, or they are on Medicaid, they are more likely not to seek these services because they don't feel like they have the available resources that they need. Accessible, we should make these vaccines more accessible so that everybody in the African immigrant communities can easily access these vaccines. These vaccines are not cheap at all. For a mere person who is uninsured, underinsured on Medicaid, it's very expensive. So having these vaccines at an affordable price might be one of the things that would help us address the low rates of vaccinations. And adaptability. Most of the homes that these people come from are low-income homes. And if they don't have enough time saved up at work, it will be hard for them to take time off to go and get the vaccine. So if we can have programs that help to adapt it to the situation, it would really help. Thank you so much.
All right, thank you so much to all of our wonderful presenters. I think you guys all really highlighted that hepatitis B and low vaccination awareness and just low vaccination rates amongst adults is not within one particular community. It's in multiple communities for multiple reasons, and we need to work on addressing those reasons. So now we are going to switch over to a discussion portion. So please, if you have any questions, feel free to drop them in the chat. And I'm really excited to chat with the panelists and hear their responses. So I'll kick off the discussion with a quick question. So we've heard multiple times that the adult hepatitis B vaccination rate across the US is about 25%. And I think we touched on this a little bit, but this number has remained stagnant for several years. And so within your communities and what you've experienced, what are some of those reasons in your field why that number has remained stagnant? There's a lot of reasons.
So I'll just provide my perspective in internal medicine primary care. I think as we found in the survey that we did, a lot of adult primary care physicians who care for adults aren't aware about the low vaccination rates, so they aren't actively talking to their patients about it. And I think we've seen with primary care physicians, I mean, they play a key role in increasing vaccination rates for all vaccine preventable diseases. And so that's one place to start, in addition to, of course, increasing awareness in the community and in general. And I must say that, we should be testing and vaccinating, not just vaccinating, but that's one piece of it.
Hi, I also think that part of the vaccine rate not being too great is it's the having a long list of risk factors and having primary care provider having to address. So assessing the risk factors, it could bring out some issue about stigma and making the patient feel uncomfortable, and for both the patient and also for the providers. So I think, and also it's a time constraint issue. So I think a lot of the time with primary care physician with so many other issues to address, they might just kind of, put it back for a later time and then keep just pushing it back into the next visit. And that could be the reason why the vaccination rate is so low.
Yeah, I think you guys said two really interesting points, and it's part of the reason why we're really excited to see what the ACIP comes up with for the universal recommendation potentially, because I think that, once one group starts with updating guidelines, it makes it a lot easier for states and other organizations to follow, because everybody bases their guidelines off of what the federal government says. So those are really, really good points. We do have a few questions from the audience, so I'm going to turn this over to Dr. Weng. So we had a question about the money the CDC is investing in hepatitis B across the jurisdictions. So can we just turn it over to you to repeat how much money the CDC just gave out in those grants and in how many jurisdictions?
Hey, this is Mark. Numbers $341 million over 5 years, 59 jurisdictions. And this is recently tweeted out by CDC Hepatitis, if you want to retweet it, if you do that kind of thing, hashtag hepatitis. We know that, just comment, like others have said, New York City, West Virginia, Florida, Illinois, there are a lot of common themes there in terms of, vaccinating for hepatitis B, but the devil's in the details. We want to pick out the common themes, but we know at the front line, it's going to look a little different how the implementation programs are implemented. So we want to support that from a federal level. Thank you.
That's great to hear, and we're really excited about those grants and to see what can be done with them. And we have another question. So it says, I'm curious if the adults who are unvaccinated even know about the vaccine. How are people being made aware to get vaccinated? That's a very great question. Does anybody have experience within the communities with how they've helped outreach these communities?
I can say, I'll answer that question. I don't think that by and large, they're aware necessarily of the vaccine unless they have an occupation where it's required, or they happen to have children. And now that children are being vaccinated, they become aware of it. So I think that's even more important reason for us to be pushing sort of education campaigns, because as we've mentioned, there are a lot of time constraints and there are a lot of barriers to having to go to your doctor just to learn about the vaccine. So learning about it and sort of through community education, I think would be really helpful to make people aware that this exists and where they can go to get it.
And I'll also say that I think pharmacies can play a really key role in increasing awareness around vaccinations and all the, basically what we're doing to increase awareness and access to the COVID-19 vaccine, we should be translating to all other vaccine preventable diseases for adults and for children. And so that's certainly an opportunity there.
And so what we've been doing here at IPHA, we have been partnering with local organizations that serve the African immigrant population. So that's one way that we've been able to reach them. So for example, local ESL classes, local churches like African churches, that has been one of the ways that we have reached that group of people. And it seems to be working, and we are hopeful that moving forward, we are going to be seeing numbers of Hep B vaccinations going up.
Thank you. So switching gears slightly, we know policy is a really big part of getting things done as well. And so I want to turn it over to Abby and ask Abby if there are any legislation that's currently circulating right now or that may be introduced that can help address low vaccination rates.
Thanks, Michaela. Yeah, we have a number of bills that members of Congress have introduced and are leading on at the moment that we think would help improve immunization rates overall. I have some of the bill numbers up here on the slide and certainly more information on the AVAC website. A couple of things that I would just love to take a moment to highlight is the Helping Adults Protect Immunity Act, the HAPPY Act, which is a lovely title for a bill, but that helps take care of some of those complications on cost barriers in the Medicaid space. Right now, there's really a disparate way of covering vaccinations in Medicaid, depending on if you're an expansion state or a non-expansion state. And when it's in those non-expansion states, even within, the cost sharing is very different there. And so this legislation is really meant to kind of create equal footing and line up more with private insurance marketplace, which does say that if it's a recommended vaccination, then it's covered. And that's what we would like to see, because I think that'll be really important to take that, that cost out of the way for beneficiaries so that we can focus on some of those other efforts around education and outreach. I would also just note, and it's not up on the slide, but it is appropriation season on Capitol Hill, which is when the spending purse gets doled out. And so, you know, members of our coalition are very much in support of money that would go towards the programs that would help hepatitis, including the Immunization Services Division within the CDC, as well as the Hepatitis Division. And I think there's been some great work on both those fronts recently in strategic plans that have come out of HHS. The National Vaccine Strategic Plan recently came out, as well as the Hepatitis Strategic Plan. And I think some of those pieces in there are really ripe to be, to receive kind of funding to make sure that implementation can come out of those as well. Other bills I'll just note are up here. The Immunization Infrastructure Modernization Act gets at those immunization information systems. We really see those as a key to reducing disparities, because we can figure out who's been vaccinated with what when and have a bidirectional exchange between the immunization providers. So whether you're going to get your vaccine in a doctor's office or in your pharmacy or through your workplace, all the partners will be able to connect to those IISs, and that's really important. The Protecting Seniors is similarly financial barriers bill for Medicare. Luckily, hepatitis B is covered under Medicare Part B, so it doesn't have those financial barriers as much as what we're seeing in Medicaid. And community immunity through COVID, I think it is very COVID specific in terms of getting those funds out the door for education and outreach. But as we heard from some of the panelists before, this is where we need trusted messengers coming from both our provider community and our trusted partners on the ground. So we would love to see more of this type of language. They're actually in the Black Maternal Health Bill, which is named the Momnibus Act. there is a section in there on education and outreach that has similar grant dollars that would go out towards reaching perinatal population. So lots of great stuff. I could go on and on, but I'm gonna stop for now.
Thank you so much. It's exciting to see there's so much that we can do. And, you know, even sharing this with your representatives and senators is really important as well to help getting them aware of these bills. And we had another question come in. This is for the whole panel. So how can we get affordable, ideally free hepatitis B vaccines for our adult population? We have community members that are interested in getting the vaccine, but it's just unattainable due to the cost. Many of our federally qualified health centers and their clinic partners are unable to obtain and offer vaccines for the uninsured and underinsured. She just goes on to mention it's really hard to do they do a lot of outreach and education, but the cost is a major barrier for many groups.
I'm certainly the not provider here at the table, but one of the things that, I think we're all very aware of in the policy space as well is the need to be reimbursing the providers who are offering these vaccines at a rate where they can afford to, have the vaccines on hand and really be making that strong recommendation. We know that some of the reimbursement doesn't always translate at the same level for the Medicaid population. And we certainly see when it comes to counseling, right? We want to make sure that there's dollars there to have providers be reimbursed for that time, for those important conversations that they need to have with the patients as well.
Yeah, I think those are really great points. And I think it really have to come from a higher level policy to help with this, and not just by, individual clinic or individual provider, because there's only so much that we can do. Definitely, having the Department of Health, local Department of Health to provide some free vaccines so that way we can give out to the patient who really needs it, especially those who are uninsured, and have some kind of subsidized program to lower the cost of the vaccine, such as like the 340B drug program, where we can create more affordable vaccines. So even if it's not free, at least it can be offered on a sliding scale, and that the patient can have it and complete the vaccination instead of having just 1 or 2 shots and then cannot afford a third one.
And I think really taking on a public health approach to vaccination is vital. We've seen with the COVID-19 vaccine, people are able to get the vaccine without looking for an insurance card, looking for if they have money in the bank to get it, they're able to line up, get the vaccine, get protected. And we should have a similar sort of approach to prevent other vaccine preventable diseases, to save money down the road, and of course, to have much better health outcomes.
Those are all fantastic points, and I think really vital in order to really addressing what we're seeing today in multiple communities. So we have a few minutes left, and we had a question come in, and I think this leads into our final question as well. So somebody is asking about the ACIP's upcoming October meeting on hepatitis B vaccination recommendation. And I also am curious to hear from the rest of the panel, how would a recommendation for adult universal hepatitis B vaccination aid providers and aid public health communities and the workers on the ground in helping to achieve the health equity for your unique communities?
I definitely think that having universal screening is a huge difference, because it's a simple message that you can give out to all provider. It doesn't make people have to think about, how to counsel the patient. It's just out there as very simple one message for everyone to get vaccinated. So it would cover everyone, and it would really improve the disparity within all the group that is being affected most by the hepatitis B. So I definitely think, that's what we've been doing at Charles B. Weng. And I think it definitely helped us diagnose more about patient and allowing more of our patient to know about their status.
Yes, thank you. And does anybody have any thoughts on the vaccination recommendation or anything else they would like to add? Any final thoughts as well?
Hey, this is Mark, CDC. ACIP work group at CDC is looking, and with CDC is looking at currently looking at the evidence base for universal vaccination recommendation in adults. So there's a meeting in June and a meeting in October. Obviously, with other things going on in the nation, the timing is a little bit tentative, but we're looking to get that presented in front of the ACIP sometime this year, hopefully. The other thing I'll say is, I think there was a question also about vaccination versus screening. Maybe not the exact question that was asked, but we do know that there's another federal advisory group looking at the universal screening question. We want to recognize that we know that vaccination and the screening the issues go hand in hand, and they're kind of complex to tease out, but we are looking at that in parallel. The ACIP work group's mandate is to just look at vaccination, but the other federal advisory group is looking at screening, and hoping to kind of merge this in an ideal way. So that's the goal. Thanks for asking that.
All right, thank you all. We are just hitting 4 o'clock now, and I think we had a really great, robust discussion, and I'm very excited to see what everybody takes home from this conversation. So thank you to every single panelist for joining in with us today. We appreciate your support and your incredible insight to the vaccination world for adults and hepatitis B, and we hope to continue to support you and all of your work. And thank you so much, everybody, for joining today's webinar. This has been recorded, so you guys will be receiving recordings and the slides as well. If you have any questions, you can please feel free to email me, and I'm happy to answer anything. We're a resource for you all. Thank you, everyone.
Thank you.
Thank you. Bye.
Thank you. Bye.